Hello, everyone, and thanks for joining COVID-19 Preparing Your OR for Elective Surgeries webinar. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode, and if you have any questions, please type them into the question section on your GoToWebinar console. At the end of the presentation, we'll have a Q&A session as well, and we'll get to as many questions as we can. But for any reasons yours is not addressed, someone will be able to follow up with you after the presentation. We like to keep things interactive, so throughout the presentation, we'll be launching poll questions for you to answer. Today, we have two presenters, David Bocanegra, Nurse Informaticist at IMO, and Janice Kelly, President of AORN Integrity. As mentioned before, if you have any questions or comments while our presenters are speaking, please type them into the questions on your GoToWebinar control panel. And with all of this being said, I would like to pass it over to David Bocanegra.
Hello, everybody. That's me on the screen. My name is David Bocanegra. I'm a nurse informaticist here at IMO. At IMO, I just want to begin with a little background here. IMO has been the primary driver behind clinical interface terminology. We began in 1994 when few clinicians were even using electronic medical records. Today, we are the premier supplier of clinical interface terminology to the US and English-speaking market, with more than 70% of acute care facilities, 4,500 hospitals, and over 500,000 daily clinician users in the US alone. Even as our customers and partners are struggling to manage the COVID-19 pandemic, IMO has been there supplying terminology-related services to help with data capture, management, reporting, and research. IMO has partnered with AORN's Integrity. We're partnered together to provide a standardized surgical procedure list solution that incorporates AORN's Integrity's expertise in developing an evidence-based surgical procedure list, and IMO's expertise in standardizing clinical terminology to help perioperative teams standardize their scheduling and documentation processes. And today on this webinar, we have joined to provide some principles and guidelines to resuming elective surgeries impacted by the COVID-19 pandemic. COVID-19 has created significant financial challenges for providers. And even as the pandemic continues to evolve, one thing is clear: the virus has already and will continue to have a significant financial impact on hospitals. As of March 14th, 2020, hospitals had been advised to postpone non-emergent and urgent elective procedures, which account for 40 to 50% of hospital revenue, and in some hospitals up to 70%. As a result, providers that operate on already razor-thin margins have seen significant decreases in revenue and margin year over year. Complicating matters more, hospital costs across the board have skyrocketed as providers sharply increase purchase of disposable personal protective equipment and capital supplies such as ventilators, beds, etc. Increased staffing, improve the provider-patient ratio, and purchase medications to combat the infection. Simply put, COVID-19 has simultaneously decreased revenue while increasing costs to squeeze margins even more. Many hospitals had canceled or postponed elective surgery procedures to prevent the spread of the disease to otherwise healthy individuals and to preserve capacity for COVID-19 patients. While necessary, this move will create hardships for these patients, as well as financial and logistical challenges for these organizations. CMS provided a tiered framework, as you see on the screen here, to inform hospitals on how best to provide surgical services to those whose conditions require immediate or urgent attention. While this framework provides guidance, the decision to resume surgery remains the responsibility of local hospitals or healthcare systems, while also considering state and local health directives. Risk and benefits should be evaluated not only for the clinical situation, but facilities must also consider resource conservation. As this crisis continues, these CMS recommendations will be refined. Surgical services are one of the most needed and essential services that a hospital can provide. To address the COVID-19 crisis, the Centers for Medicare and Medicaid Services had made some recommendations for resuming elective surgery. These recommendations include, among other things, considerations regarding the availability of ventilators and personal protective equipment while limiting exposure of patients and staff to the COVID-19 virus. Proper use of resources requires that you schedule as many cases as possible while also considering patient safety and the availability of supplies and equipment as shortages continue to linger. Hospitals around the country As hospitals around the country begin to resume surgical operations, healthcare leaders need to focus on the short-term effects of the pandemic as well as any downstream impact. Some of the larger hospitals may have as many as 5,000 or more cases to be rescheduled. Operating rooms that typically run at capacity need to determine how to get all of these cases back on the schedule efficiently. Accurate case time averaging and analysis of historical utilization data will provide the insight needed to target the number of daily operating hours required for an average surgery day, and this will allow for informed scheduling decisions and improved scheduling efficiency when putting that backlog of cases back on the schedule. As previously mentioned, COVID-19 has created a difficult financial scenario for most hospitals. In April 2020, an April 2020 National Hospital Flash Report from Kaufman Hall highlights the financial scenario of the average hospital through the month of March given COVID-19. The report states across the board, volume declines were a major contributor to the steep decline in margins as providers postponed elective procedures to free capacity and equipment for COVID-19 patients, and as individuals canceled appointments for fear of contracting or unwittingly spreading the virus. Operating room minutes were down nearly 20% compared to that same period last year, and were more than 25% below budget. The nation's hospitals continue to incur high expenses in March, despite seeing far fewer patients. Expense results for the month reflect organizations' efforts to rapidly build staffing, drugs, supplies, and capacity in response to the COVID-19 pandemic. So now more than ever, surgical suite efficiency and margins are needed to help providers sustain operations. As a significant contributor to operating margins, it is clear that the surgical suite will need to recover quickly, but more importantly, it will need to operate more efficiently than ever before. Providers must take dramatic steps to maximize productivity and control costs to help hospitals regenerate much needed margins to sustain operations. Providers must act now and quickly to tackle these challenges listed on this screen to improve surgical suite efficiency and margins. Safety protocols to implement could be social distancing, patient screening upon arrival to the hospital, enhanced cleaning procedures, the requirement of face masks or other personal protective equipment as appropriate, and then of course setting limitations on the number of people in the office or waiting areas. Surgical scheduling is the crux of OR workflow. Without it, the OR workflow can become convoluted and inefficient. Surgical preferences vary widely without properly organized and consolidating these preference, supply, and resource costs can balloon very easily. Coding is critical to reimbursement as well. Inaccurate coding can lead to denied claims, partial or delayed payment. So along with an economic crisis, the coronavirus, COVID-19, has also created a healthcare crisis. History has shown us that healthcare is usually immune from recession, as people will continue to need healthcare services regardless of what is going on in the world. COVID-19, however, is causing a situation that is quite different. People with certain chronic medical conditions that put them at higher risk of being infected are being told to stay home, yet these are the people who need active supervision and proper follow-up the most for their underlying healthcare concerns. So due to these restrictions, they're just not seeking healthcare in the usual volumes. And of course, elective surgeries have been canceled or postponed, causing hardship for the patient and the healthcare entity. All processes within the workflow should be evaluated to ensure that they include the appropriate safety precautions for patient and staff during COVID-19. The same holds true with surgical scheduling. When considering all of the ramifications of COVID-19, are changes necessary to improve safety? Are these additional precautions clearly defined through all workflow steps? As discussed, Perioperative services provide a majority of the entire revenue for a hospital. As these hospitals resume normal perioperative services, it is vital to include steps to ensure proper reimbursement. That being said, in your process, does the scheduler have the correct CPT codes for pre-authorization? Are checks and balances in place when CPT codes are incorrect or unavailable? How does the denial process work, and who owns the responsibility for follow-up? Does the patient have the correct admission class for the intended procedure? Review of case time averages and OR utilization in general should be done regularly, as inconsistent case time averaging can lead to under or over utilization issues. Providers should take the necessary steps now to mitigate the challenges associated with surgical scheduling, managing preference cards, and coding accurately to ensure that the surgical suite is an efficient margin-generating revenue center for the institution. Elective cases have already started to back up. Providers should be prepared to maximize revenue and margins through efficiency and productivity. Providers across the country are actively building their OR recovery plan. What steps are you taking to plan your recovery? I know this has been a lot of information, and before we talk about increasing efficiencies in surgical scheduling, there are many things that need to be considered prior to resuming elective or non-essential surgery. At this point, I'd like to turn it over to Janice Kelly, and she will continue.
Okay, thank you, David. As David said, I am Janice Kelly, the president of AORN Syntegrity, a subsidiary of AORN, the Association of Perioperative Registered Nurses. AORN's mission is to promote safety and optimal outcomes for patients undergoing operative and other invasive procedures. We unite and empower perioperative nurses, healthcare organizations, and industry partners to support safe surgery for every patient, every time. As David mentioned, we have been a partner with IMO for the last 3 years, collaborating on a standardized surgical scheduling procedure list. Now that you know a little bit about me, let's get started on my portion of the presentation. On March 18th, in response to the COVID-19 pandemic, CMS recommended limiting non-essential care to conserve critical resources such as personal protective equipment or PPE and limit exposure of patients and staff. A month later, on April 17th, AORN, the American Hospital Association, the American College of Surgeons, and the American Society of Anesthesiologists issued a roadmap for resuming elective surgery after the COVID-19 pandemic. A couple days after the roadmap came out, CMS provided recommendations to reopen facilities to provide non-emergent, non-COVID-19 healthcare in many areas that have low or relatively low and stable incidence of COVID. In mid-May, AORN, AHA, and AdvaMed released recommendations to support healthcare organizations and medical device representatives when resuming elective procedures. The objective today is to provide you an overview of these recommendations to help guide your organizations to safely resume non-essential surgery while protecting your patients, staff, and visitors as you transition from crisis mode and prepare for the next wave. So in order to ensure the recommendations for safely providing non-essential surgeries are implemented, organizations should establish a governance committee. The governance committee should consist of surgeons, anesthesia, nursing leadership, infection control, environmental services, and executives. The focus of the committee is to provide the governance on the resumption and prioritization of non-essential surgeries during the COVID-19 pandemic and future waves. The committee should utilize the most up-to-date guidance from federal, state, and local health authorities, as well as appropriate associations. During the ramp-up period, at least daily huddles should be held. Once an organization has returned to 100% pre-COVID capacity, the governance committee should continue to meet as needed to monitor and prepare for a surge. The government's committee should monitor the incidence and trends for COVID-19 and their relevant geographic area using data from federal, state, and local public health authorities. The governors across all 50 states have eased restrictions as the COVID-19 curve flattened. As states and geographic areas open up, surges in the number of infections or hotspots may be seen, such as in long-term care facilities, food processing facilities, correctional facilities, businesses, or even specific regions of the country, such as the potential second wave occurring in the South and the West. With the easing of stay-at-home orders, Memorial Day travel, and protests against racism have occurred, spikes may be seen in some parts of the country. On June 8th, there were 28 states where the number of new confirmed COVID cases increased from the prior week. These surges can have an impact on healthcare supplies, resources, and capacity. The goal is to monitor the spread and the intensity of COVID-19 to prepare health systems for an increasing number of ill people and avoid crisis in standards of care, such as extending the use of surgical masks and other supplies, sterilizing N95 masks, and potentially placing patients and staff at harm. Also, did you know that NHSN has a COVID-19 module for organizations to submit surveillance metrics? Approximately 56% of acute care hospitals and over 53% of critical access hospitals have submitted data to that NHSN COVID module. The committee should also monitor the usage of supplies and resources to ensure the organizations have the proper inventory of non-crisis level equipment and supplies, as well as for potential surge capacity. Case scheduling of elective procedures should account for a proper inventory of PPE, including PPE for any medical device representatives essential to an elective procedure. Not only supplies, but medical equipment, beds, medications, they should all be monitored. How many anesthesia machines were repurposed as ventilators? And are they available for your OR? Were any ORs, pre-op and PACU areas repurposed for additional inpatient beds, and have they been converted back? Do the elective procedures require an inpatient stay? And what is the expected length of stay? What other resources are required for the procedures you plan to restart, such as blood products, ICU beds, ventilators? Has your organization established a minimum availability of beds and other medical equipment needed to cover elective surgery admissions? For example, some hospitals have established a 20 to 25% minimum availability of beds to be maintained to support elective surgery admissions and an influx of COVID-19 patients. So if a surgical patient needs a post-op bed and the bed availability is at 20%, another patient may need to be discharged to support that elective procedure. Staff availability, especially in those facilities and hotspots where staff may be physically and mentally exhausted, should be monitored. What is the status of your furloughed staff? Are they working elsewhere to support COVID-19 hotspots? Are they on the schedule to support other areas of the hospital? And when can they return to the OR? For example, many anesthesia providers went to COVID-19 response teams to be what we call the super tubers, or they are working in the ICUs to support anesthesia machines repurposed as ICU ventilators. Will those providers be available to support the OR? How long will they be needed elsewhere? Will you need to supplement with locum tenens? The staff you have, what are their skill sets or experience? For example, if you're starting with a specific service line or specialty, do you have the staff who are experienced in that specialty? Are new staff having to be hired, and do they require training? What resources will you have to train and precept these new staff? Can you start with surgeries in an owned or joint venture ASC to start recouping some of the margin because you don't have capacity at your hospital? Are these ASCs equipped to handle a new service line or specialty? Some hospitals are even talking about creating consortiums and building domestic manufacturing for PPE to reduce their reliance on importing. Others are sharing educational resources to ensure adequately trained staff, or maybe even sharing medical equipment to assure the availability. And then finally, turning on the open sign is not going to be effective for those patients who feel they can wait to have their procedures performed. Emergency room visits in the U.S. dropped by more than 40% in April because patients were hesitant to visit the ER. Therefore, communication with patients will be important more than ever. CMS released a guide yesterday on what patients should know about seeking health care, which recommends that patients do not postpone necessary care. They talk to their healthcare provider about the precautions being taken in the offices and hospitals, to consider telehealth, and what to expect when seeking health care, such as wearing a mask, avoiding crowded waiting rooms, limiting the number of visitors, screening before entering a facility, and washing their hands often. People trust hospitals, but are doubly afraid of them right now. Patients have put off elective procedures will need to be reassured it is safe to enter hospitals or ASCs. Organizations need to develop the right approach to engage patients and make them feel safe. Some organizations have conducted online surveys to fully understand patient concerns. In addition, patients have experienced loss of income or change in insurance and may not be able to reschedule their planned procedure. In a survey done in mid-April, over half of the 1,000 people surveyed indicated they will wait 4 months or longer before scheduling an elective surgery in a hospital or ASC. Some facilities have created videos or having surgeons and nurses reach out to patients to discuss their fears, or they're doing branding initiatives to be transparent about what they're doing to make things safe. The hope is to accelerate the return of patients to the healthcare facilities for care. The next recommendation focuses on COVID-19 testing to protect staff and patients. The Governance Committee should address policy and procedures on the requirements and frequency for patient and staff testing based on the availability and accuracy of tests and results. Although supplies of tests are increasing, it may still be difficult to find a place to get tests performed. Most hospitals have the capacity or the capability to test, but only about a quarter of ASCs have on-site testing. There are 2 tests for COVID-19. The viral test that indicates if a patient has a current infection at the time of testing, and generally this is the most reliable test. However, a few days may pass before the virus starts replicating in the throat or nose, so the test may not identify someone who has been recently infected. Some viral tests are point-of-care tests, meaning results may be available in less than an hour, while other tests are sent to a lab to be analyzed that can take up to 2 days to receive the results. The second test is a serological or antibody test, and that indicates if a patient has been previously infected. Due to an influx of potentially unreliable serological antibody tests coming to the market, the FDA does require these tests to be authorized to remain on the market. It is still unknown if a patient who has antibodies is protected from getting sick from the COVID-19 virus. Antigen testing has recently become available as well. The test identifies people who are currently infected with the coronavirus by detecting the virus protein. The first of these tests was issued emergency use authorization by the FDA on May 8th, but more testing needs to be done to confirm the accuracy of the test due to false negatives. If they prove to be highly accurate, the antigen test can provide results in just a few minutes and could be used to screen patients and staff. So organizations should review the turnaround time of the testing capability that they will utilize. They need to understand the accuracy and the timing of these tests to ensure COVID-19 test occurs as close as possible to the patient's surgery date. Consider the false negative tests and the need for retesting. Some organizations have initiated viral testing on all patients scheduled for procedures and surgeries, and some are doing it only on those that generate aerosol. They educate patients to shelter in place after testing until the surgery date to limit potential exposure prior to surgery. Staff and medical device reps should be routinely screened for COVID-19, including fever, cough, shortness of breath, chills, muscle pain, new loss of taste or smell, vomiting, diarrhea, and sore throat. Healthcare worker and medical rep testing, viral testing, may occur when testing capacity has increased or when antigen testing has proven to be accurate. The lack of appropriate PPE was a major issue identified with the COVID-19 pandemic. The governance committee should focus on adequate availability of PPE, including supplies for potential second wave, as well as supporting elective procedures. On the CDC website, there is a PPE burn rate calculator spreadsheet or the NIOS PPE tracker mobile app to estimate how many days PPE supply will last given current inventory levels. Determine the appropriate amounts of PPE to keep on hand if one has not been established by state or local authorities. For example, in New York State, there is a requirement for every hospital to have 90-day supply of PPE. Other organizations have determined an X number of days on hand with projection of new inventory arrival for the next 2 weeks. Daily huddles help organizations monitor their PPE usage and plan usage for the next several days. Staff and medical device rep training should focus on the appropriate use and proper use of PPE according to non-crisis evidence-based standards of care. The proper procedure for donning and removing PPE should be reviewed. In some cases, retraining may be needed because of the crisis standard use of PPE. Evaluate policies for the conservation of PPE, such as extended use and reuse or reprocessing PPE. On June 7th, the FDA announced it was changing what types of respirators can be decontaminated for reuse. Decontamination systems can only be used on non-cellulose compatible N95 respirators. Banned from reuse are any respirators that have an exhalation tubes or N95 masks made in China. In addition to PPE training, consider education on disinfecting surfaces, infection prevention, and hand hygiene. Organizations should establish a controlled point of entry for all healthcare workers, patients, visitors, and medical device reps to ensure all individuals have masks and to check for symptoms. Develop policies related to visitor and student restrictions. When will you allow students back into your organization? Some organizations are restricting visitors and students until a continued downward trend in the geographical area is observed of COVID. If there is uncertainty about a patient's COVID status, PPE appropriate for clinical tasks should be provided for surgical teams. For example, some organizations require PAPRs for all team members for ENT and GI procedures. CMS recommends that healthcare workers wear surgical masks at all times and N95 masks and face shields when there is a higher risk of aerosol transmission. CMS recommends patients should wear a cloth face covering that can be brought in from home. Another function of the Oversight Committee is to establish a prioritization strategy appropriate to immediate patient needs. It should follow a collaborative process that adjusts to local, regional, and national trends in COVID and is sensitive to resources, priorities, and patient needs. The committee should start by looking at previously canceled and postponed cases and verify the true status of those procedures. As mentioned earlier, patients may be fearful, no longer have insurance, or no longer have the means to pay for the surgery and need to postpone indefinitely. Facilities need to identify what their true backlog really is by reaching out to surgeon offices and confirming the updated status of canceled cases. In addition, many surgeon offices have been shut down or dialed back significantly, so there are less patients that have been added to the queue. Talk with surgeon offices and referring physicians to determine the time it will take to ramp back up and book new cases. Next, the committee needs to look at the true capacity. What is your available OR minutes based on the following availabilities? Physical OR rooms, PACU, inpatient beds. Did OR or PACU rooms get repurposed? Did anesthesia and perioperative staff get reassigned, relocated? And don't forget to include time to wait, the wait time for entry into the OR for intubations and extubations for staff without N95 mask or face shields, and the time to wait to clean before you enter the OR to clean the room. These will decrease your true capacity. What is the availability of various supplies? such as basic PPE, implants, medications, instruments, or trocar desufflation filters for laparoscopic procedures? What is the status of ancillary staff, such as your environmental services, your lab, your RAD? The focus should not be on how quickly you can be back to pre-COVID status, but how safely you can accommodate the current demand. Other decisions your facility may want to make is whether you will suspend block times for a certain period. Evaluate unfulfilled surgeon block time so all unused time is released. Will it be released to a first come, first serve time slot? Will you extend weekday hours or run on the weekend? A recent study showed that less than 15% of facilities are running surgery on weekends. Will you start in the outpatient or ASC setting? At what capacity do you feel is logistically feasible to start? Maybe you start at 25% versus 50% and move capacity up by obtaining data to support further expansion. What is the average length of stay after your procedures? What resources does a procedure typically require? The Michigan Value Collaborative and the Michigan Surgical Quality Collaborative have reports that display historical resource utilized by surgical service lines, such as the median inpatient length of stay, ICU rate, ventilator utilization, blood product utilization, and discharge dispositions outside of returning to home. Prioritization is the next step to consider. There are several tools that can be utilized to help determine prioritization for surgeries. Some hospitals are using ASA scores and starting with patients with AS scores of 1 or 2 only, those likely not to have complications and require admission. Other organizations are using the medically necessary time-sensitive scoring system or utilizing specialty prioritization guidance. The government's committee should also review any limitations that may impact non-essential surgeries. For example, what is the availability of post-acute care facilities that may be required? Is it safe for the patient to even go there, or can the patient recover safely at home? What is the trend related to the COVID numbers, including prevalence, incidence, and isolation mandates? Are there capacity limitations related to inpatient beds, intensive care units, ventilators, staffing, supplies, PPE, etc.? Everything that was reviewed to determine the appropriateness to resume surgery should be monitored to determine if it's safe to continue with non-essential surgeries. Some of the post-COVID-19 care specific issues that you should address are policies to mitigate, or policies related to address specific care issues related to COVID-19 and the postponement of non-essential procedures. Guidelines need to be considered for whether you're going to repeat lab results, radiology exams, history and physicals need to be updated, and possibly reconsenting the patient for surgery versus using what was already available prior to COVID. How can telehealth be utilized to reassess the patient for comorbidities, especially if they're a COVID-19 patient or a patient under investigation? Screen patients the night before appointment for symptoms of COVID-19 and check their temperature on arrival. How will you handle COVID-19 patients? What will be the environmental cleaning process, and when will it start after a case that should be based on air exchanges of your OR? As mentioned before, assess the need for post-acute care facility safety versus returning to home. Remember, some discharge locations require 2 negative COVID tests prior to accepting the patient, regardless of the original test results during pre-op. Adhere to standards of care protocols as much as possible, such as enhanced recovery protocols to decrease complication rates and optimize length of hospital stay. Are there any needs to revise checklists and timeouts to address COVID-19 risks, testing results, and ensure the proper PPE is being utilized? The governance committee should develop guidelines on who is present during intubation and extubation and the PPE required. Include the time to wait after intubation and extubation within the procedure time, as this will add to your OR capacity. Remember to focus on healthcare worker well-being as they continue to provide much needed care, treatment, and support. Provide healthcare workers information and resources to support physical, emotional, social, financial, and spiritual well-being. Resources should focus on self-care, how they can arrive home safely and not spread COVID-19 to their family, such as maybe taking off their work clothes at work and changing into other clothes, or taking off their clothes before they enter their house and jumping into the shower, whatever they feel more comfortable with. And then you might want to also offer some stretches and meditation to release tension. The last recommendation addresses policies to mitigate the spread of COVID-19 in your organization. Facility social distancing and safety policies should be applicable to staff, patient, visitors, and medical device representatives in all areas of the facility. As mentioned before, control the entrance into the building to a few areas. Provide masks to those visitors who are not wearing one. Post signs to remind of social distancing. Mark off 6-foot areas for where patients and visitors may stand in line. Establish engineering controls to facilitate social distancing, such as spacing chairs in the waiting room 6 feet apart, or placing plexiglass or glass to separate patient and visitors from registration staff, or have virtual waiting rooms where patients and visitors wait in their cars and are provided a text or phone call when to enter the building. Remove reading material from your waiting areas. Consider scheduling COVID-19 positive patients that must have surgery to the last case of the day and recover the patient in the OR suite. Designate recovery locations that are separate from known areas. If space is an issue, consider maintaining low patient volumes or extending practice hours. Limit the number of visitors for the patient. Some organizations have instituted 1 visitor per perioperative patient. Complete a terminal cleaning of all areas prior to reopening at the end of each day. If available, utilize robots to clean so staff are not exposed during disinfection routines. Review turnover procedures with environmental services, especially for procedures that produced aerosol transmission. Depending on air exchanges, wait 20 to 30 minutes after surgery completion or extubation before entering the OR room to clean. During the COVID-19 pandemic, patients were open to telehealth and home-based care. Continue to utilize telehealth and technology as needed. For example, continue the use of telehealth to bring the medical device rep into the OR. Utilize notification technologies to deliver education, appointment and screening messages to communicate new procedures at the facility to patients, such as wearing masks, visitor restrictions, reminder of reporting of appointments, and completing any screening tests. So to recap, the recommendations, the most important step is to establish that governance committee at your organization to ensure the most current recommendations are followed and relevant data is utilized to resume and continue non-essential procedures. Initiate policy and procedures for COVID-19 testing to protect staff and patients. Know your PP availability and establish policy and procedures to ensure proper levels and use based off of the most current recommendations and non-crisis standards. As noted, June 7th, FDA made some new recommendations, so you need to stay up and current on the new recommendations. Develop a prioritization strategy to address the backlog of surgical cases in the future queue and address the care-specific issues related to COVID-19 and postponement of non-essential procedures. And finally, consider how your facility can mitigate the risk of COVID-19 as you resume and increase the capacity of non-essential surgeries and care. Now I will hand it back over to Jordan for a poll question.
Thanks, Janice. If everyone could refer to your screen for the first poll question. If your organization has already resumed surgery, at what capacity is your OR? Less than 20%, 20 to 30, 30 to 40%, or greater than 50? I'll give you a few more seconds. All right. It's looking like most are greater than 50%. Okay, now we're going to go back to David.
So we talked about this transition from crisis mode to recovery. The recovery stage after a crisis is often a forgotten step. In crisis communication, after managing a crisis, hospitals will try to resume normal business operations as quickly as possible, and very often they skip the recovery stage entirely. While successfully navigating a crisis is vital to the recovery stage, it is crucial in restoring the organization's financial stability and reputation for the long term. Simply stated, the overall goal of the recovery phase is to move from crisis to resuming normal business operations, while at the same time rebuilding trust in the organization. Taking time to debrief after a crisis is vital. One of the first steps the organization should take is to recognize those people who were involved in successfully managing that crisis situation. It's crucial that these people know that their efforts were appreciated and will go a long way in establishing the cooperation needed to move forward. Next would be the development of a communication plan to assess what worked and what didn't work, and more importantly, why certain actions worked or didn't work. Lastly, an organization should examine their current situation and determine if there are any opportunities to make positive changes to strengthen its reputation. These don't have to be complicated. Simple things like acting quickly and being transparent about how the crisis was handled, going the extra mile for your patients, of course, keeping promises, and dialing up the human side with patient interactions. These strategies will go a long way. The effective management of resuming normal perioperative services while also considering adding in an extensive backlog of patients whose surgeries were postponed due to the CMS recommendations regarding COVID-19 is going to require planning. We will discuss some of the things that can increase efficiency with surgical scheduling and reimbursement. Getting back to normal surgical operations can be difficult for the many reasons shared today. Also consider that a fully staffed operating room is very costly to run. Some studies estimate that expenses can exceed over $1,000 per hour. While in COVID-19 recovery mode, the importance of accurate surgery scheduling should not be understated. Incorrectly scheduled surgeries can result in increased costs to an already financially burdened facility due to improper room setup, the wasting of supplies, and complete loss of revenue in circumstances where the patient is in the incorrect admission type. Many of these factors can be reduced or avoided completely simply by having a healthy surgical scheduling dictionary. A healthy surgical scheduling dictionary must contain a few key elements. We see these as being regular maintenance, good governance, plain language, clinical procedure naming, a consistent naming convention throughout, and no ambiguity. Effective management and maintenance of the surgical scheduling dictionary are vital to scheduling efficiency. Due to the ever-changing and evolving nature of the perioperative space and surgical techniques in general, without an effective management strategy, these dictionaries can become outdated really quickly. Dictionary maintenance must start with good governance. There must be a process in place that ensures that newly added procedures are not duplicative, are unambiguous, and most importantly, make sense clinically. Poor governance can lead to the creation of multiple duplicative terms, a lack of or loose naming convention, which among other things can cause ambiguity and confusion as to what is the intended procedure. The above examples can also lead to a very challenging search experience when booking cases. When scheduling, the inability to quickly find the correct procedure name, lack of or inconsistent CPT codes is very frustrating, and it can lead to a close enough approach whereby the person booking the case will pick a procedure that is not exact but close enough to communicate a general idea of what the surgery will be. There are many problems with this approach, however, perhaps the most severe being that the case that is being scheduled is not the case that's going to be performed. And it should be quite apparent that this can create a potentially dangerous situation and would require a process that contains multiple comprehensive checks and balances to prevent a patient from having the wrong surgery. It should go without saying that an incorrect or wrong site operation, aside from most importantly being damaging to the patient, is costly not only financially, but also to the reputation of the institution. Preference card management can be tedious in cases where dictionary health is not an issue. Imagine a procedure dictionary that lists procedures that aren't used anymore, or perhaps include many duplicative or ambiguous terms. These examples make CPT-4 coding, mapping, and efficient management of the preference cards nearly impossible, Accurate time averaging will also suffer due to multiple practitioners scheduling the same operation but stated in different ways. So I will turn over to another poll question.
Thanks, David. If everyone could refer to your screen, which of the aspects of surgical dictionary health do you find most important? A, regular maintenance, B, good governance, C, clinically relevant procedure names, D, consistent naming conventions, or E, no ambiguity. All right, I'm going to give you a few more seconds. Okay, it's looking like good governance one. Back to David.
Hey, thanks. So let's talk about surgical scheduling dictionaries. Scheduling effectively requires an understanding between your ordering physician and those tasked with preparing for the surgery. This communication translation is often difficult. Schedulers not being sure exactly what the intent of the surgeon is can lead to selecting a suboptimal procedure, leading to delays, waste, and insurance denials. This communication problem sometimes stems from inadequate governance of your dictionary of surgical procedures. Over time, this dictionary can be full of similarly named procedures added from different service line leads that needed something scheduled urgently and found that the existing procedures did not cover the intent of the surgeon, or maybe that their service line was not authorized to perform the procedure. These duplicative procedures can lead to confusion when scheduling, excessive and duplicative preference cards, and a high maintenance burden. Having a dictionary policy in place to review what gets added or changed can pay dividends in helping streamline communication. Regular maintenance of your dictionaries is also important. Even a strong governance policy will miss things on occasion and cause issues. By regularly ensuring that your list of procedures accurately reflect those that your healthcare organization performs and that your CPT mappings are accurate, you can reduce the overhead of regular preference card reviews or updates and build a solid data foundation. Your surgical scheduling dictionary is where the intent of the surgeon is recorded, so its health is vital to scheduling and adjacent workflows. When thinking through how to improve scheduling, efficiency, and overall financial performance, it is important to look at the entire workflow and understand how various pieces connect. When you understand the scheduling workflow, the quality of your data, where data is input, who reviews that data, the financial outcomes of the entire process, you will put yourself in a much better position to improve the overall performance of your operating rooms. To ensure that you have this understanding, a hospital must first set out clear and measurable improvement targets. If basing your targets on financial outcomes, your metric could be decreasing denials due to improperly scheduled procedures. If you're basing this on improving OR efficiencies, some key efficiency metrics include accuracy and case duration estimates, the percentage of on-time first case starts, the percentage of cases that had pre-anesthetic checkup prior to surgery. A couple of other metrics: patient in to incision time, measuring the average time that elapsed between the patient entering the operating room and the first incision, and then the average turnover time, how long it takes to get the room changed out to receive another patient after a surgery on a previous patient. To guide you in achieving your goals, evaluate your current scheduling process for understanding and to give you context in your decision making. Interviewing those involved in the process, from schedulers to surgeons to nurses to coders, it can lead to insights into struggles that might not be apparent with just looking at a workflow diagram. As you examine this process, you might find that there are insufficient checks and balances in place to ensure strong data throughout. You also might find that the issues can arise because of unclear ownership of certain scheduling activities or lack of clarity and communication between personnel during this workflow. Let's talk about preference card management. Preference cards present a unique challenge to a hospital. It has been established through numerous studies, including Zygorakis et al., and I really hope I'm pronouncing that person's name correctly. He estimated for a single service line, a single neurosurgical department, there's approximately $960 of OR waste per case. Based on their volume, that equated to $242,968 a month, and annually about 2.9 million a year, so almost 3 million a year. Clearly, there are significant savings to be had in optimizing the use of surgical supplies to minimize this waste. The revenue and environmental implications are staggering. Zygorakis et al. Go on to recommend price transparency of supplies, education about OR waste to surgeons and nurses, and preference cards reviews with clarification of supplies that should be opened for the case versus just available and as needed to reduce waste. Preference card reviews are time consuming and can suffer from a lack of clarity about which cards need the most attention. In addition, duplicative cards can increase the burden and confusion during the review process. In order to help ease this burden and promote success in your preference card optimization efforts, it is imperative that you identify the procedures that are actually being performed in your organization and create a healthy surgical scheduling dictionary. Doing this prior to a large-scale preference card review can lead to a better focus, a shorter list of cards, and a better sense of priority for the review. Hospital process and surgical scheduling. Efficient surgical scheduling can be very challenging with everything that is demanded of it, such as special requests from surgeons, differing staffing requirements, and the potential for adding cases to an already full day. Some fundamental principles should be followed to make the management of surgery schedule much more straightforward. At a minimum, the entire patient care team must have the same understanding of the intended procedure to ensure correct room setup with regards to supplies, equipment, and personnel. Also, all hospitals have a process in place to schedule surgery. The request for an operation, whether on paper or electronic, at a minimum, should ideally include the patient's pertinent medical information, including allergies, diagnosis, reason for the surgery, admission status, clinical description of the intended procedure with the expected CPT codes for pre-authorization, and of course, any special requests. This process at a minimum should also include guidance for specific scheduling situations, such as add-on cases, as well as changing or canceling scheduled operations, as these situations will have a real-time effect on operating room utilization. Surgical schedulers must have excellent communication skills as they're continuously engaging with physicians, patients, and ancillary staff, and it is also essential that the scheduler is familiar with all aspects of the scheduling process and operating room routine. An in-depth understanding will enable them to be flexible when contingencies arise. All of these contingencies must be managed with a minimal impact on operating room utilization. Coordinating these and other variables can be frustrating. It is essential for the scheduler to maintain a positive attitude and assume a proactive approach when changes occur in order to problem solve and make appropriate accommodations effectively. Pre-authorization of cases with the patient's insurance carrier is essential to receiving proper reimbursement. Most surgeries require insurance authorizations, and in some cases, the schedules work on short notice, especially when trying to add on urgent surgery to an already full OR schedule. When booking an operation, the scheduler must know the exact intended procedure to be able to obtain the insurance pre-authorization efficiently. It's vital at this point in the workflow that the scheduler has the correct CPTs to ensure the best chance of reimbursement. Incorrectly pre-authorized surgical cases can result in little to no reimbursement, especially if the case is one of the many operations in which the Centers for Medicare and Medicaid Services deem as inpatient only. They have determined that for certain surgical procedures require a full day, at least a full day of monitoring and recovery time as an inpatient. And if any of these CMS inpatient only procedures are scheduled incorrectly as outpatient surgery, in many cases the hospital will receive no reimbursement. And this rule not only applies to the costs related to the operation, but can extend to all charges for the entire hospital stay, including any other hospital services the patient may have received. We discussed the potential for improved financial outcomes earlier, and a key place that denials can be reduced is when pre-authorizing a procedure before it is performed. On an earlier slide, we talked about the importance of your surgical dictionary, but another key element of a healthy dictionary is CPT code mappings. When taking a surgeon's order and setting the schedule, it is crucial that the proper CPT code be used when pre-authorizing. While a CPT code might come from the surgeon, it is helpful to have current CPT code or codes mapped to the procedure being scheduled to facilitate this process. Accurate CPT mappings coupled with built-in EMR alerts can also bring attention to situations like the presence of a Medicare inpatient-only CPT code. For schedulers or pre-authorization personnel, knowledge of the need for an inpatient setting can be the difference between a full reimbursement for a procedure and an outright denial. And these types of denials can be costing hospitals hundreds of thousands of dollars or more. Proper dictionary health and data-driven alerting can lead to better financial outcomes. So some key takeaways for improvement. A healthy surgical scheduling dictionary should contain only appropriate active procedure terms mapped to up-to-date industry standard code sets. Causes of unhealthy dictionaries are multifactorial and require a defined program to achieve and properly maintain good dictionary health. This can only be achieved with regular review, executive support, and good governance. Effective communication is vital to all aspects of medical care. All involved in patient care must have the same understanding of the patient's condition and needs. If this is not the case, then there's a breakdown somewhere in the chain of communication. Techniques to enhance communication do not have to be multi-stepped or complicated. Something simple as such as a quick staff huddle before the start of a surgery is a great way to ensure that all are on the same page. When instituting any process, you must have as a starting point the appropriate personnel. It is essential for the success to start with the right staff and a formal training program. Create and use processes. Processes, even very involved ones, save time. If they don't, then this one itself would be a reason to re-examine your process. This process should be centered around patient flow. Improving patient flow would be the most significant change to affect efficiency and productivity. Ensure that overlap of tasks and responsibilities is minimal and only present to ensure patient safety. And create handouts of what to expect prior, during, and after surgery. An information sheet about the planned surgery will ensure that the patient understands the operation as well as provide insight into these operative phases. So in conclusion, healthcare facilities should be able to begin performing elective procedures again if they follow certain protocols, according to guidelines released by the Centers of Medicare and Medicaid Services. When resuming elective surgery, it is important now more than ever to strive for efficiency. Active recovery phase planning should include a review of workflows to address areas where changes are needed to increase efficiency, combined with proper dictionary maintenance and confirmation that all procedures have correct CPT codes for maximum reimbursement and decreased denials. Preference cards should also be reviewed and updated as appropriate to confirm the optimal use of surgical supplies and equipment. It is vital now more than ever to ensure high value in all aspects of surgical care. Working through the backlog of elective cases that were put on hold will be more of a marathon than a sprint. Patients should be carefully selected based on COVID exposure, age, overall physical status, any risk factors, and surgical indication. Facilities must also have an acute understanding of their inventory and utilization rate of personal protective equipment and other supplies as the stress on the supply chain continues. The roadmap to resuming elective surgery should be progressive and cautious, especially in the area of pandemic focus, as healthcare facilities remain committed to working with federal and state policymakers to safely provide their communities with the help that they need during the COVID-19 pandemic and beyond. I believe that we have another poll question.
Yep, thanks, David. All right, I'm going to go ahead and launch our final one. I know we're running out of a bit of time, so would you be interested in learning more about IMO or AORN solutions? Okay, give it a few more seconds. Awesome. I'm going to go ahead and close out, and now we can start our Q&A session. We have about a few minutes, so if you don't mind entering in your questions into the GoToWebinar console, and please excuse any brief silence while we're looking at questions. Okay, David, I think this is a good question for you. Who from an organization should be in charge of data governance?
So that the answer is it can be very complicated. It requires many people to be involved. I mean, you want an executive sponsor for sure, so that you can know that you have someone to lean on to get to make changes or to dictate policy or help create policy. You'll need coders. You'll just need a lot of people in the organization to make sure that when procedures are being added. They're added appropriately. They're correct. They're coded correctly, and they're not duplicative or ambiguous.
Awesome. All right, just a reminder to put any more questions in as we're about to close out. All right, I think we are done. Thank you all. I hope you have a great rest of your day and things were informative for you. If you have any questions, please email your IMO client executive or email sales@imo-online.com. Thanks for attending and please stay safe out there.